All right, so I have on my clock that it's 2 o'clock your time, so that means we are going to get started. So this is Women's Health. All right, so this class will be a little bit different than PT and definitely different than CRD. There is probably no math in this class and no story problems related to math. So that might be a relief to some of you. Yeah. Because it is a little bit different format, I do want to review some of the things in the syllabus and kind of what the semester is going to look like. Um, so I do want to just highlight some things in the syllabus. All right. So first thing that let me just
Recording in progress.
First thing I want to talk about, we're just going to go in order of the syllabus because that makes my life easier instead of jumping around and less risk of making you motion sickness. The assessments for this class are checkpoint quizzes. These are based on lecture materials. They are cumulative throughout the course. They are a mix of multiple choice and short answer questions. They are open book, untimed, one attempt, and these will be on ExamSoft. So there are 6 of them throughout the semester that are outlined in the schedule. I'm not 100% sure on how ExamSoft works. Is like if you can open it and go back to it. I feel like you probably need, if you're going to sit down and do it, you have to just get it done and submit it. But you would know more about that side of ExamSoft or Examplify than I do. But I would just set aside the time and do it in one setting and complete it. They're generally about 20 to 30 questions. And so shouldn't take you too terribly long to do. You have about a week, 6 to 7 days to do them. You've probably heard maybe some scuttlebutt from other classes that there was a podcast that you had to create in this course. We have, or we, I guess I'm the we, have changed it from a podcast to a critical discussion in healthcare policy and practice. There are a lot of reasons for that. That we don't need to get into here, but I think it's better for you all to do a critical discussion board versus a podcast. There are some technical things that go into making a podcast as far as the recording and the coordination of the group work. This makes it more of an independent project. We'll talk more about that when we talk about the projects in the class. You're going to be given an assigned response or assigned prompt to create or to respond to. That's 13%. You need to engage with other people who are talking on the discussion. That's 5%. And you will have to put together one presentation, and then you'll have to engage with 2 other presentations. There's going to be 9 of these throughout the course. It'll make more sense when you see the assignment outline. If you're not doing the main discussion, you are assigned to 2 other discussions where you're engaging, and each of those are worth 4%. The end of the class, we will have a PSA public service announcement video watch party. I'm going to put you in groups, and you're going to create a 3-minute public service announcement on a women's health topic. So that is the group work that is staying. I will get those assigned within the next week or 2. And so you can start working on those, and you have all semester to work on those and finish those for the last day of class. Since that is group work, if there is somebody you absolutely cannot work with, you cannot find it in your heart to get along, to get this project done, like it will be the end of the world, it will destroy you, please email that to me by the end of after either right now while I'm talking and you're not listening to me, or right after class. If there is somebody in class that you just it's not gonna go well, please email me so I can try to avoid that in groups. I can't make everybody's wishes come true as far as groups, but if there is a significant conflict, I do want to try and avoid that so that everybody can have a good experience. But that being said, I will be assigning the groups because it is important for us to learn to work with people that we don't normally work with. Everybody has different talents, and that has been one of the feedback that I have gotten, is that the group work in this class really promotes getting to know your peers, and maybe you aren't assigned to work with them in other areas. So we are going to keep that, and I will be assigning them. Much like CRD, there's attendance and participation. This means you're present in class, you're participating in class discussions, activities, meeting the deadlines, professional communication. So, I really try to be understanding. I know that, when I was in school, they used to tell me school is my top priority, and that's cool when I'm a single person and I have nothing else going on for me besides school. And it was a completely different world, 20 years ago. And so I do try to be understanding when you can't make it, or when you're unable to meet a deadline. I just ask for clear communication. All right. I can't help you if I don't know what's going on. So please communicate with me, over communicate with me. That is the best way for us to all get along and get through the semester together. Are there any questions on this, the assignments and the grading? Yes, Jesse.
For the checkpoint quizzes, it's on ExamSoft, so we need passwords for that, right?
Yep, I'll make sure you have all that. I will post it in the announcements every week. Yep, I'll post that the quiz, the checkpoint is ready. Here's the password, and then you can take it. And then the due date, I try to remind you in the announcements. And then after everybody has finished the checkpoint, I send through ExamSoft a way for you to review it. And I think you're able to review it. So I do have it set up for that as well. That's a great question. Yes, Jessica?
Also, for the checkpoint quizzes, will they be like posted on a Monday and we'll have like whenever it's due, or is it going to be posted on the day that it's due and you just have to do it by that?
It'll be posted. My goal is a week in advance, so you'll have a week to work on it. It'll be posted 6 to 7 days in advance of the due date, so you'll have 6 to 7 days to complete it.
For the critical discussion in healthcare policy, you said if we're not in the main discussion, would be in the engagement. What do you mean by that? Like we have to still complete both, right?
I'm going to explain that further when we get into the assignments. So just hang on until we get there, please.
Okay.
All right, there is a book that's available on Access Pharmacy, but I did download the chapters and put them on Canvas, so you don't even have to go to Access Pharmacy. The chapters are in Canvas. This is to enhance your knowledge. You are not necessarily required to read them, but there are some chapters that you might want to read that could help. Like for next week, the chapters on birth to menarche, you might want to read because that stuff can get kind of tricky. So attendance is going to be randomly taken throughout the semester, either by putting your name in the chat. I'm sure Dr. Park is teaching in this class. She'll probably have you sign in on a sheet. It can happen at the start of class, at the end of class, in the middle of the class. Sometimes I take screenshots. If you are not here when attendance is taken, you are absent. All right. If there are 3 or more unexcused absences, then you will fail the class. That's 20% of the class. This class meets once a week. If you miss more than 20% of the class, then you will fail the class. And excuse absence are at the discretion of me, the course coordinator. So again, just please make sure you're having open communication with me with where you're at. One of the things I do want to highlight is that we are going to have some guest speakers come in who are going to share their experience with women's health diseases or disorders. We have somebody coming in to talk about her cancer diagnosis, her breast cancer diagnosis. I'm trying to get the person who's come in has talked about her infertility. There's another person who talks about their postpartum depression. I expect I don't love when your cameras are off. It's very clear that I prefer them when they're on. But when we have a guest speaker, I want the cameras on because it is absolutely demoralizing to talk to a black screen. So when we have a guest speaker, cameras are on, everybody's facing forward, and everybody's paying attention because they are not adjunct. They are not being paid to teach you and share their experiences. They are here out of the kindness of their heart to share their trauma for your development, so you understand what patients go through with those disease states. And kind of hear what it means to be getting chemotherapy and the cost associated with that and the support that's needed. Same thing with infertility. All right. So I draw a hard line on when our guest speakers here that we are giving them our full undivided attention. All right. If your camera is off without talking to me and letting me know that there's an extenuating circumstance during those presentations, you will be marked as absent. It's the least that we can do for people who are volunteering their time to help us learn and understand disease states. All right, you understand the in-class participation from CRD that's participating in the chat. You don't have to chat to everybody. You can chat privately to me. There is also an opportunity for us to engage in women's health topic things that come in the headlines or in the news, a discussion board that I put up. I want that to be very casual, but I do want you engaging. If you see if you see a topic that interests you, I want you to look at it, respond to it. If you are scrolling your Instagram and you see something like last year, for instance, all the new data came out on the HPV vaccine and how effective it was. So that would be appropriate to find an article and post that on there like, hey, I just found this in the news about women's health. We're talking about this in class, and sharing it with us. Those types of things. All right, so everything is outlined here. please recognize that the schedule might be in flux a little bit. I'm still waiting on some confirmation from the speakers, but I will update you on Canvas if there's any changes, especially as it relates to in person or on Zoom. So this is the lecture schedule, and then here is that critical discussion is going to be posted. And this is the yellow is the critical discussion due date. The green are the checkpoints that are due. And then the pink purple is when the engagement is due. So everything is clearly outlined. These critical discussion and checkpoint dates are probably not going to change. So they're going to be very solid. Those are not going to change, probably. So everything is located here for you. Everything is due at 23:59 Eastern time. So that's 11:59 p.m. Eastern time, unless it's otherwise noted. Okay. I think that's it for that. So these critical discussion in healthcare policy and practice. So there's a lot of controversy that not controversy. There's a lot of high emotional topics in women's health that can lead to some controversy in policies and how we address things. And so we're going to be looking at these things that are happening in women's health, like paid family leave, / maternity leave or parental leave, the effect of the Dobbs decision on women's health and reproductive health, how women age in place, how substance abuse substance use disorder affects women. You're going to be exploring these topics and how they affect the women, the patient, how they affect the providers, how they affect the family, how they affect society. And you're going to be giving a prompt, all right? And you're going to prepare a statement on that prompt. So you'll be given an overall topic, and then each person will be given one perspective. So I'll show you the first one that we're going to do. And this is going to come out to group 1 right after class. All right, so group 1, everybody who's assigned to group 1, many women are under pressure to return to work after childbirth for various reasons, one of which is lack of job security while she is absent or financial pressure. Discuss the current laws, federal and Maryland state versus other states that protect or lack thereof women after childbirth, and compare the U.S. system with other countries of similar economic and social status. So that's a really broad topic to respond to, right? So I've broken it down, and we have Alam going to respond to this prompt from the medical provider's view. And so these are questions that should help guide Alam's response to that prompt. We have Yadiel talking about the patient's perspective, the postpartum women, and which questions Yadiel should address in his response. We have Heidi talking about family members and how these parental leaves affect family members. And there's questions for Heidi to incorporate into her response. And then we have Michael looking at the employer's perspective of these parental leave policies and questions to guide his response. All right, so everybody is working individually on their section, and then somebody's going to put that together and post them on the discussion board on Canvas. So there is the discussion board. So in 2 weeks, somebody, whether it's Heidi or Yadiel or Alam or Michael, they're going to compile all that together in one response and hit reply here and put their answers here, their typed up information there. And then there are people who are going to be assigned to respond to that. All right. So So this gives more information on how your written response should be developed and how it should be put together. It gives you an example of things to consider when you're doing your response. We'll talk about this peer response in a second. And then there is the rubric. Everybody, again, is going to be graded individually on what they put together. So make sure that you put like Michael would put employers and put his name in parentheses behind it. So I know which section belongs to who. Here at the bottom of the assignment, and these are all available on Canvas, is the schedule. You will never have 2 weeks in a row of responding to these or creating these. So do be mindful of that. So everybody is given a critical discussion number, and I will email you on this date with your prompt and the questions that you need to consider answering. And then you need to post it to Canvas under the appropriate discussion board by this date. Now, the responses are, this is the information for the engagement. Because it would really suck if I had you all write all this stuff up and nobody read it, right? And nobody learned anything from it. It would, that's good for your learning, but we all our purpose is to inform others and educate others. And so you're assigned to engage. So on week 1, Sama, Ernesto, Jose Ivan, Keandra, Alicia, and Masa are assigned to respond to the main discussion. So the discussion will be posted by 1/28, and everybody in this box here should have responded and reflected 2 times by 2/4. And I cannot have you all waiting to 2/4 because the engagement requires Ernesto to reflect on what Heidi said. And then it requires Jose Ivan to maybe respond to Ernesto's reflection and say, oh, that's not exactly what I took from that. Here's what I took from it. Or, oh yeah, I agree with your reflection and but I want to add this part to it. All right. So you cannot be waiting till the last minute to do these because you are required to do 2 responses, a reflection and a response. All right. Yes, Ernesto.
So this is the date, for example, the first one, that's the date that it's the 128 is going to be the day that we are going to start to answer to reflect on those prompts, right?
Yep. Yes. This is the date that it's going to be posted and available for you to start doing your responses.
Dr. Hall, just to be, sorry.
Sorry.
Oh,
I'll go first. Sorry about that. Just to be clear, out of the engagement, from the point of view of someone in the engagement part, one would say you would respond once to the initial reflection post and then do 2 peer responses to other members in the engagement group or whichever of the posts.
yeah. So you're going to have an initial reflection. So what is your initial reaction to the main post? And then you're going to have 2 responses to other people.
Okay, so other people. All right, thank you. Sorry about that.
Yeah, no, that I wasn't talking clearly. In my head, because I developed this, it all makes sense. So I'm having a hard time. I've been sitting with this for 3 weeks, so I am having a hard time articulating because but yeah. So you're going to do an initial response reflection to the main discussion, and then you'll do 2 responses. And the people who post the main discussion will do the main discussion, and then they will do 2 responses to other people's reflections. If you are engaged in part of the engagement group, this is what you're going to be graded on. It is very straightforward. All you have to do is try, people, and put some effort into this. Okay, this is not meant to be hard. This is meant to be reading and conversational and getting us talking about things that we might not normally talk about. Yes, Jess.
So for the reflections, and the 2 peer responses. You don't have to put all 3 of them like in one paragraph. It can be like you do your initial reflection. Well, this is a question, not a statement.
Yeah.
But you can do your initial reflection, and then let's say I did 1 peer response on Tuesday, and then Thursday I see somebody else responded, and then I can respond to that post, right? Okay.
Yes, perfect. That's exactly how it works. You post your initial reflection and then you look for other places to respond. So this is why it requires everybody to be on top of this and do this. Right, and I've been told that I left somebody's name off. Please take a look at these and make sure that you're assigned to 2 engagement sessions and 1 main discussion. Right, so you should be assigned to 1 main discussion and 2 engagement. I will need to double check my work, but it's easy to overlook something when you are the only one staring at it over and over again. So if you don't see your name, please let me know and I will work on that.
Professor, excuse me.
Yes.
Where can I find that document?
Yep. So under, I don't know how yours is broken up, but mine under modules, there is the critical discussion and healthcare policy module, and then there's the main discussion instructions and the engagement instructions there.
Okay,
And
thank you.
Jess also says it's in files too. All right. So this public service announcement, I did put some slides up there on what a public service announcement is. The slides have links for you to watch what a public service announcement is, because I realize that a lot of people don't understand what a public service announcement is. You didn't grow up in the 90s with like, the more you know, this is your brain on drugs with the egg in the frying pan. So I did put some links there. If we have time, I will spend some time maybe next week or the following week going through those slides, but they're there for you to look at and what we're getting at. So again, please tell me if there's absolutely anybody you can't work with, send it in an email by the end of the day today. I'm going to get those groups assigned. I'm going to assign you a topic and you're going to create a public service announcement. It should be geared to people on campus. So we're educating people on campus. So we're educating people on campus about access to contraception. We're educating people on campus about prenatal care. We're educating people on HPV vaccine, but your audience is people on campus. All right. And so I want you to, whoops, this still says Brightspace. I should say Canvas, but you all know. But you're going to get together with your group and you're going to submit an outline of what you're going to cover in your PSA by February 25th. And the reason we do this is I'm going to give you feedback on that outline, like, oh, this going to this area is too deep. Oh, have you considered maybe talking about this aspect? So I'm going to give you feedback on what you're planning on covering in the PSA. Oh, you have way too much stuff. We have to cut it down. You're never going to be able to get through all that information in 3 minutes. So this is to ensure that I get you feedback before you go on spring break. All right. And so that you have, when you come back from spring break, you'll have about 5 weeks to do the videoing and complete the task. All right. So this is to ensure we all are staying on task and we don't get behind. The video is going to be 3 minutes long. Everybody in your group has to have a speaking part in the video. All right. And so make sure you follow these guidelines. It's going to be, the video is going to be due by April 28th on Brightspace or on Canvas. And then we will have a video watch party for our last day. Students have gotten mad in the past because they were marked, the rubric is down here, and most of the grading comes from the content. So is your content accurate? Is it inclusive? Is it accurate? Are you persuasive and relevant? Are you creative and originality? And so a lot of students have gotten mad because they were reading off a script while they're doing the video. I mean, this is a 3-minute video across 3 to 4 people. That's not very much script for you to memorize. None of the PSAs you see on TV are people reading. So you do need to put some effort into this. If you are just reading, if everybody's just reading in the PSA, that makes it not creative, original, that makes it just reading information to us. So you will be marked down if you are just reading the information. So please be mindful of that. All right. And then you also need to create a social media post. So if you were posting this to your Instagram or your X or your Facebook, what would the caption be and what hashtags would you use for this video? So I think that is all the like orientation stuff for the class. Thank you for those of you who checked. I will update. Looks like I must have missed something. So I will update that. So again, double check to make sure your names are on the main discussion and on the engagement.
Dr. Hall, I have a question.
Yes.
So just to be clear, I am the group with the topic 1. So all the group one is going to reply all the information that we work in. Then the engagement group have 1 week to reply to reflect about our answer to the question of topic 1. Do the group that have the topic, do we need to also be in the engagement, like reply if someone put something, I need to answer that or have my opinion about everything, or only 2?
So you have to reply twice. You in group 1 who are creating the initial post have to reply twice to other people.
Okay, thank you.
Yep. Yes, Jesse?
So does the rest of the class also reply to that main discussion, or just
Oh, that's a really good question. Sorry, I didn't mean to cut you off. My brain is going, I need to do better at letting people talk. So the rest of the class, nobody is restricted from engaging. I would hope that you're reading for your own benefit to understand these topics to a deeper level, that you're reading them. And I encourage you to read them all and participate in them all. I would love it if you would do that. But I understand that that's a lot on a week-to-week basis, potentially. So if you want to engage, I do want you reading them. I do want you engaging with them, but you're only required to do that for your 2 assigned ones. But yeah, that's an excellent question. Everybody's putting a lot of work into these, and I think it's best for all of us to learn from them. So. All right, so action items for you are to double check and look for your name on 2 engagement spots and 1 main discussion, and let me know if you don't see it, and then send me an email if there's somebody you absolutely can't work with. Those are our action items for tonight, okay? And now we will get into our topic for today. Any other questions before we move on? How did I miss? Oh my, I missed a whole. This is what happens when you do stuff at 1 o'clock in the morning. This is why you should go to bed and get 6 hours of sleep, y'all. Do as I say, not as I do. You thought late nights were over once you graduated, right? Maybe there's people that are better at managing their time and don't let their perfectionism, OCD get in the way. That's definitely not me though at this point. I'm sorry, it is really cold here and it is really dry. And so like I just cannot keep my throat not all dried out. It's supposed to get to like -15 this weekend. How do you people from the warm climates feel about that?
That sounds crazy.
All right. So we're gonna, start with an introduction to women's health. What is women's health? Right. And so our objectives for the lecture today are to define what women's health is, identify policies influencing women's health, understand the socioeconomic factors that affect women's health, review psychosocial factors that influence women's health, review major policies influence women's health and research, highlight gender differences in morbidity and mortality between men and women. So in most of my PT lectures and throughout the rest of the curriculum, I really try to use more inclusive language and say pregnant patients and lactating patients. In this class, because it is a women's health class, we are focusing on women. I will be probably saying women more frequently, and I'm not trying to be not inclusive, but it is the nature of this class. It's a women's health class. So I don't mean to be, singling out our pregnant patients and our lactating patients. All right. All right. So how do you think we define women's health, or how do you think women's health has been defined historically? It's quite interesting, the evolution of the definition of women's health. And so historically, women's health has only been related to their reproductive organs. So can they have a baby? Are they trying to have a baby? Is that, are they healthy during pregnancy? Did they deliver the baby? Okay. Can they have another baby? Like women's health has historically only been about their reproductive organs. And I don't know, as a woman, I feel like there's a lot more to me than my reproductive organs. And so in the late 90s, early 90s, the Fourth World Conference on Women came out and said, hey, women are more than their reproductive organs. There is more to their health than just whether they can have a baby or not, or whether they're trying to have a baby or not. And so this Fourth World Conference was trying to promote equality across the world as it relates to gender and women. And so they determined that women's health was the state of complete physical, mental, and social well-being, and not just the absence of disease. All right. So they're saying like it is your complete physical, mental, and social well-being, and not just do you have a disease or not. All right. And so women's health involves their emotional, their emotional state, their social state. So do they have the supports in place that they need to be healthy? Do they have help with childcare? Do they have, access to medical care through insurance and things like that? And their physical well-being. So are they healthy overall? Are they free of disease from a physical standpoint? Right. And women's health, everybody's health is determined by social, political, and economic context. But up until the 90s, we did not believe that women's health was affected by the social, political, and economic factors in a woman's life. That this is a relatively, the 90s wasn't that long ago. And so been an interesting shift here to define women's health. But again, focusing on that it's the physical, mental, and social well-being, and not just whether a woman can have a child or not. or if there's something wrong with their reproductive organs. So, thinking about how women, we have to think about women and their place in the workplace and how that has shaped health and how that has shaped their role in society. And so in the 1890s, there were laws in place that said, hey, if you're a woman, you can't work. And if you can't work as a woman, what if you're a widow? What if your partner abandoned you with kids? What if you are divorced? What if you never married? Who's going to take care of you if you can't work? And so that's when they created mothers' pensions, and mothers' pensions was money, kind of like social welfare to help support women and children who didn't have a male figure to support them. In around the 1940s, we start seeing married women working primarily at home. So that they're working in the house, in the home, managing the household, managing the children. And we see single women starting to venture out into the workplace and get traditional women's positions. When we say traditional women's positions, we think things like secretaries, typists, bookkeepers, teachers, and nurses. All right. But still, the majority of women were staying home and working from home, managing the household and the children. But in World War II, we saw all our men, or a lot of the men, go overseas to fight the war. And so who's going to build the planes? Who's going to do all the things we need to do over here if all our men are across the ocean fighting this war? And so this is World War II is when we see Rosie the Riveter. And so being a military family, when we were in Florida, I actually got to meet a Rosie the Riveter who worked for like 60 years in an airplane factory. She was 90 some years old, like almost 100 years old, talking, and she gave a talk about how she worked building planes during World War II. And it was fantastic to, see this woman talk about her experience working during this era. Right. But the war ended and the men came back and the women went back home. So they filled the need, and then a lot of them just went home. In the 40s and 60s, we start seeing more women working outside the home. And then we start seeing the number of working hours increased for those women that are working outside the home. And this kind of correlates with like the sexual revolution of the 1960s because there was an increased access to birth control in the 1960s. So women had access to birth control. They're better able to control their reproductive life and postpone having a baby. And so they're allowed to work more. And so you see this kind of coincide with the increased use of birth control. And then we get to the 2000s. In 2006, we had 67 million women employed and 75% of them were full-time. In 2020, about 60% of women were employed. In 2022, it dropped a little bit. We did see a drop in women in the workforce during COVID because kids were at home. There was no childcare. Kids were doing school distance learning from home. And it was mostly the women that were giving up their jobs to be able to manage that. So we did see a little dip from 2020 to 2022 of like 1 million women leaving the workforce to take care of things at home. So, that is the history of women in the workforce. Let's look at some of the policies that have been created over time that influence women's health. In 1935, we have the Title V Social Security Act. And so this allocated federal funds to the states to develop maternal and child health programs, right? These funds help supported initiatives like prenatal care, which we know is very instrumental to women having a healthy pregnancy and childbirth. It also supported initiatives for postpartum care. and health services for children. So this Title V helped ensure that women received the necessary care during and after pregnancy and that their children were also cared for. In the 1960s, we see the development of Medicaid. So Medicaid, aid for the poor, care for the old. Medicare is for the old people or disabled people because we care for the old and we care for the disabled people. Medicaid is for the poor. We aid the poor people. All right. So Medicaid and Title X are created. Right? Medicaid gave even more. They expanded the access to prenatal care. But also family planning. So family planning includes contraception, planning to have, like if I'm planning to have a child, then I get on prenatal vitamins before I start trying to get pregnant so that I can ensure that my pregnancy is as healthy as it can be. So that's part of family planning or delaying pregnancy. And then preventative screening. So your pap smear. This is when we started saying like, hey, we know pap smears can detect cancer. And so we need to start covering those with our insurance and have access to them. All right. And again, this is for low income women. The thing about anything that goes into policy for Medicaid and Medicare often becomes policy for commercial health care in many instances. So this was the start of where we see preventative care and preventative screenings being covered by commercial insurances, because commercial insurance isn't going to do anything that Medicaid and Medicare aren't doing because they're for profit, right? And so Medicaid and Medicare are a service, and so they are designed to operate at a loss, not a profit. So once Medicaid and Medicare start covering services, then commercial insurance is forced to start covering those as well. Right. We see Title X also created, and this helped with family planning and contraception. It also provided education and counseling on breast and pelvic exams, cervical cancer screening, so that pap smear, and treating for STDs and HIV. It also gave information about preventing STDs and HIV, which helps keep patients healthy, and gave resources for pregnancy and pregnancy counseling. In the 1970s, we see Title IX come out, and this prohibits discrimination against women in education programs. So women at universities and colleges, if the university or college is receiving federal money. This applies to all aspects of discrimination. This is in salary, employment, promotion, but most people focus on Title IX as a sports issue. So are the women athletes getting the same amount of scholarship opportunities as the men athletes? All right, so that's mostly what people think of as Title IX, but if you were to get pregnant while you're here in college or at the university, Title IX would protect you. All right. And those types of things. We also see in 1973, Roe versus Wade was a Supreme Court decision that legalized abortion in the United States. So Roe versus Wade gave the U.S. women in the U.S. the legal right to abortion, no matter what state you were in. This was revolutionary for women. And because of this Title X, this family planning and contraception, abortions actually decreased when we increased access to family planning and contraception. So really fascinating to know that the more time and effort we put into family planning and getting people appropriate contraception and education, abortion rates actually go down. During the same time, we had the Equal Rights Amendment. I don't know if y'all have had enough capacity to be following the news, but all like during November and December, they're like, Biden needs to put the ERA into the Constitution. And it's like, well, Biden can't do that. So it's seen a resurgence in the last couple months here. But the ERA is the Equal Rights Amendment that proposed a new amendment to the Constitution that would guarantee that equal rights could not be denied of sex based on federal, state, or local law. So surprise you to know that women do not have a constitutional right against discrimination in the United States. Did you all know that? Because it's man. And right now we're with a Supreme Court that takes everything very literally. And the Constitution was written by white men to keep white men in power. So this ERA amendment was like, hey, women should be equal too. We did the suffrage, and we got our voting rights, and we should be not like nobody should be able to legally discriminate against us. And we pushed this. There was some drama with it. It took forever. If you're going to make a new amendment to the Constitution, you have to have like, is it 2/3 or 3/5? I think it's 2/3 of the states ratify it, and it took forever for all the states to ratify it that were needed, and it expired. So it just sat there. It just sat there and expired.
Which amendment was this one that you're saying that expired?
What's that?
Which amendment was this one that you said that it was expiring?
This Equal Rights Amendment.
Okay.
It sat there so long. They put an expiration. So when they introduced it to Congress, they said it needs to be ratified by this date. You need to have 2/3 of the state, whatever the cutoff is, ratify it by this date. And it was like a couple months after the expiration date that they got the last ratification. So this has never been put into our Constitution because it met its expiration date. There's been a resurgence in interest in this, and people were saying that Biden can just make it happen, and he can't. If you know anything about US government, he cannot make an amendment. An amendment has to be approved by the states. But everybody was feeling very panicky, or not everybody. A lot of people were feeling very panicky after the election, and were trying to get to backdoor this amendment. Needless to say, it's still sitting expired. In 1993, we have the Family Medical Leave Act. So you'll hear FMLA. And so this allows people to take unpaid, they are not getting paid for this. They are getting $0 for this. But they can leave work for if they have a serious illness, if they have to care for a family member who has a serious illness, or they have a newborn child. So that typically affects women, right? Because outside of the serious illness, who's taking care of family members typically who are really ill? The woman. Who's birthing the child and taking care of the child? The woman. So this primarily benefits women. And it says that if you take this leave off, this FMLA, your job is secure until you come back. You get up to 12 weeks of leave and your job is secure. You can come back. You come back to the same type of position with the same pay. Maybe not the same exact position, but the same type of position and the same pay as you did when you left. So this was job protection for women who needed to take leave to take care of their families or take care of themselves. It also helps other males and non-binary people, because they also get the benefit of, if they get ill or if they have to take care of a family member, that their job is protected for 12 weeks. Right. And then in 2022, we have the Dobbs decision. And so this is Dobbs versus Jackson Women's Health Organization. And this overturned Roe versus Wade. So it eliminated the United States right to abortion. And it, by overturning Roe versus Wade and saying women in the US do not have the right to abortion, it left it to the states. So each state is deciding whether or not their state is going to allow abortions. So, I'm in Colorado, very close to Texas. If I am pregnant and I go to Texas and I have a complication, I cannot get an abortion. I have to go back to Colorado or back to another state that allows abortion. Right? In the South, in Florida, Georgia, the Carolinas, like it takes a lot of distance for you to get to a state that will allow an abortion. So this is this significantly impacts women's health because depending on what state you are in determines whether or not you can get an abortion. And we'll talk about this more, but an abortion is not just for an unintended pregnancy, right? People get abortions for a lot of reasons. And so like abortion is a medical procedure. And a lot of times when you have to have a procedure to save the woman or the pregnant person's life, that procedure is called an abortion. And even those are restricted. All right. So, diving more into this abortion, because this has been in our lifetime, in your pharmacy career, this has been a huge change, right? Because you've been in pharmacy school around since 2022. And so we see that the Supreme Court ruled in the Dobbs decision that states there's no U.S. right to abortion, and states can make their own policies on abortion. And so when we said that the U.S. There was no right to abortion in the U.S., all these states had laws on the books regarding abortion that came into effect. Right? And so they can start protecting or banning abortion. And you've probably seen this like shortly after this decision, there were several states where abortion was on the ballot for the state. Right? There's medical abortion, and medical abortion is with mifepristone and misoprostol. We'll talk about these drugs a little bit more. And these drugs can be used in the FDA packaging. They can be used up to 10 weeks of pregnancy. The World Health Organization has a little more liberal definition in that they can use it up to 12 weeks. So that is a medical abortion. And over half of the abortions in 2021 were medical abortions where they took one or both of these pills. All right. And so up to 12 weeks is the first trimester. So this is the first trimester of pregnancy, which Dr. Park will teach you more. All you ever wanted to know about pregnancy and lactation and how that works if you're not familiar with it. So then COVID comes, and to get these medicines, you had to have an in-person visit. You had to have an in-person follow-up. And so that is a barrier. If I have to come in person to get the medicine and I have to have an in-person follow-up, and in COVID, nobody was doing in-person visits. So that really limited care. So in December of 2021, the FDA removed the in-person dispensing requirement. So that increases access to this medication for patients, which is a good thing because if you increase access, you don't risk being too late to get the medication if you need it. Right. And in January of 2023, the FDA approved a protocol for pharmacies certified by the manufacturer to dispense the mifepristone directly to patients. Prior to 2023, it had to come from the manufacturer or it had to come from the clinic. Now, pharmacies can do that as long as they're certified. But then in December 2023, we see that there's another Supreme Court case where AHM, the Alliance for Hippocratic Medicine, this is a very conservative Christian organization that what they do is they go and look for cases to challenge women's health issues as it relates to abortion. So they filed a case against the FDA saying the FDA didn't do their job. These drugs are not safe, even though these drugs are actually safer than say, some of our blood pressure medicines, some of our other medications that we use, they're actually pretty safe. But this organization is saying that the FDA didn't do their job, and so we should remove the FDA approval of mifepristone. All right. This was very contentious last year, but the Supreme Court ruled in June 2024 that AHM had no standing. So basically, no harm was coming to them by mifepristone being FDA approved. So you don't have standing. You have nothing. You don't have a leg to stand on. You don't have a complaint in this case. Like this drug being FDA approved doesn't harm you, is essentially what the Supreme Court said. All right. And that there are lots of places that you have conscious objection. So if you don't want to prescribe it, don't prescribe the medicine. Right. So this was a huge relief because I was very anxious And a lot of people in the medical world were very anxious about this because if the Supreme Court says, yes, you know what, AHM, you're right. The FDA didn't do their job. This drug is not safe. What does that mean for all the other drugs out there? What does that mean for our trust in the FDA? That is a slippery slope to get judges deciding what is appropriate for clinical trials and safety and efficacy. I don't want any judge telling me which medication to take and which medication I can't take. Right? So if the Supreme Court would have ruled with AHM and said, yes, the FDA didn't do their job, that discredits everything the FDA has ever done. So you see why these cases are so consequential? Right. I tried to find an updated number for here, but there are between 19 and 40 pending litigations as it relates to reproductive health and rights in the US. It is constantly under attack. All right. Do y'all need a break or you want to keep going? 5-minute break?
Break.
Okay. I have 2:58, so 5 minutes is 3:03. All right, I have 3:03, so we will go ahead and resume here. Can you see the slides? Okay, great. Thank you for the thumbs up. All right, so looking at some of the socioeconomic factors affecting women's health, we are seeing now in education that women have surpassed male enrollment in secondary education, so that's college and university. So women account for about 56% of enrolled students. And then in the, when we're looking at the salary and the workforce in 2022, women comprised 57% of the workforce. And 60% of pharmacists are women. So yay, pharmacists, right? So, pharmacy is a job where, there's more women than men. It used to be when I entered, it was more 50-50, more 45-55. We've seen a trend towards more women going into pharmacy in the last several years. And so 60% of women or pharmacists are women. And that's one of the reasons, we might consider is because pharmacy is one of the most equal pay jobs that there are. So that means for every $1 a man makes in pharmacy, a woman generally makes a dollar too. Where in other careers, you like maybe engineering, a man might make $1 and a white woman might make 80 cents, and a woman of color might make 70 cents or 60 cents. So that's what we mean when we say that there's equal pay. And even but in 2001, we see that women did make more money, more per dollar than men did. So, all right. Next, we need to look at benefits that affect women in the workforce. And so paid family leave, there are 13 states that mandate paid family leave. So again, remember, paid family leave is not available to in the US. It's not a constitutional right. It's not dictated by Congress. So there are states that have paid family leave. Those are California, Colorado, Connecticut, Delaware, Maine, Massachusetts, Maryland, Minnesota, New Jersey, New York, Oregon, Rhode Island, Washington, and the District of Columbia. You'll notice that most of those states tend to trend more Democrat, more blue. And those paid family leaves are administered in various ways. I'm not exactly sure on all of them. I do know that Colorado's is very new, and you actually pay into your own leave. So a portion of your check is removed, and then if you have to use the leave, that you get money from that pool to pay you during that time. And it's not paid at 100% either. It depends on a lot of things. So these, state paid programs are very different for every state, different to manage, different on how they're administered and how you can get them. So that is something to consider. If we look here at this graph here, this looks at the US as far as paid leave for new parents compared to the rest of the world, and US is dead last. There are 0 weeks of paid leave offered to US parents. So it is like the absolute worst in the developed countries, and even some not so developed countries on the list. So really sad to see that. Paid family leave is not just for people who physically have a child. So my husband had paid leave from the military as the secondary parent. So he got 3 weeks off. Now they've done away with the primary and secondary. And if you are a new parent, whether your partner has the child or you adopt, you get 12 weeks off paid leave in the military. So paid family leave is for both parents, right? Because we're trying to get away from it's the woman's job to take care of the children, right? This is a partnership, or it should be a partnership when we're considering who our partners are. One of the things that really affects, and I see this so often on like the mom's Facebook pages, is the cost of childcare is so prohibitive to women out in the workplace. Especially if you don't have a terminal degree, like you're a pharmacist, a physician, engineer. If you don't have a terminal degree, it's very hard to make enough money to justify, the trade-off of paying for somebody else to care for your kid and going to work, because childcare on average is $12,000 a year, but can be up to $20,000 a year depending on the area. So, that's, you think about that in the concept of a year, but in Maryland, our infant care costs us $400 a week. That's $3,200 a month. That was more than our rent/mortgage. And while I understand, it's really important for my child to have very safe care and to have them readily available, I'm not discounting the work that they do, but how can you afford that payment? And that's for one child, let alone people who have multiple children, right? That's a huge amount of money. Other things that affect the economics of women's health are the Affordable Care Act, so the ACA. This is also known as Obamacare. I'm sorry, I keep messing around with my screen because something is just not. Ever since I came back from the break, I'm having issues having it set up the way I like it. So I'm sorry if it's coming across on your end.
Can I ask you about the childcare, because I've heard a lot about that.
Yeah.
And so is it because in other countries, like a lot of kids are being taken care of by just a single adult that is making it more affordable? Like what can the US do in terms of policy? Like are the states just like limiting the amount of kids too much, or what is it? Where's the I assume there's like multifactorial.
Yeah, that's a really excellent question, Jose Ivan. So why is childcare, so expensive in the US compared to maybe other countries? And the answer is because other countries the government subsidizes their childcare. So childcare, daycare, preschool is free or subsidized by the government so that it doesn't operate it is a service to the community. So it operates at a break even or a loss, where childcare in the US is privatized. And so childcare in the US is owned by big equity firms who want to make money, who want to make a profit off of childcare. And because you need to have so many like the ratios, like when you have infants, you can only have 2 infants or 3 infants per provider. So your ratio is very small. So you have a high overhead with the staff that you need to employ to care for a lot of children. But the number one answer is that places like the UK, Finland, Norway, the government subsidizes the childcare so that the parents don't have to pay the whole price. So it would take an act of Congress to get childcare costs in the US to decrease. So we're moving on to the Affordable Care Act. The Affordable Care Act does not cover any kind of childcare. It is purely health insurance related. Affordable Care Act is actually also known as Obamacare, right? And the Affordable Care Act was very revolutionary for commercial healthcare. So before the Affordable Care Act, if I was diagnosed, so in the US, our insurance generally comes from our employer. Right? When I quit my job, I lose my insurance because my health insurance comes from my employer. I go to get a new job and I have to go through a prior authorization of whether I'm able to be covered at my new job's insurance. And prior to the Affordable Care Act, if I had cancer, it would be very difficult for me to get new insurance because that's a pre-existing condition. So I could get insurance, but they would not cover anything that is related to cancer, or even if I'm in remission, even if I'm stable, my new insurance would not cover any of my pre-existing conditions. So like me, I've had a precancerous mole removed. I would not be eligible for insurance that would cover any skin cancer. That's what was happening before the Affordable Care Act. So the biggest thing that the Affordable Care Act said is that these commercial health insurance cannot deny you coverage for pre-existing conditions anymore. So that's huge when our insurance is attached to our job and we don't stay in our jobs for 30 years like my parents did. My parents stayed at their jobs for 30, 35 years. There's no way I'm going to be at Notre Dame in 20 years. No way. Right. So it was really important that when you switch jobs and you switch insurance, that you're able to get the coverage that you need. Also, the Affordable Care Act said that you have to cover women's preventative health. That you have to cover that, and you have to cover it 100%. So you have to cover well woman visits 100%, no copay, no co-insurance. You have to cover gestational diabetes screening, HPV DNA testing, because we know that's the best way to determine what type of HPV you have and whether it's one of the aggressive ones that can cause cancer or not. STI counseling, HIV counseling. So all of these things had to be covered for free. No copay, no co-insurance. Now, some of these things have been peeled back by legislation from Republicans saying we're doing too much. We can't afford all this, which is crazy because these are all not crazy, bananas. These are all preventative treatments, preventative care that prevents something worse from happening. Like if I can catch my precancerous cells on my pap smear and have them removed and not have cancer, that is much more affordable than getting cancer and the insurance company paying for the cancer or the government, like whoever paying for the cancer, right? Like bananas to me. All right.
It sounds like what Mike Pence did with the HIV coverage, or like outbreak in Indiana when he was a governor. It ended up costing the state of Indiana a lot more money because of all the people that got infected with HIV because he opposed to needle sharing.
Yeah, an unintended consequence of them making a law based on their morality. I'm not familiar with that case, but that tracks with everything I know about these situations. So, all right. So, looking at all these things combined that we have talked about, socioeconomic status is one of the largest detriments of health and healthcare. Women are more likely to live in poverty than men because many women stay home to raise their family when their children are young. So they're not earning retirement during that time. They're not earning an income. And if the partner leaves, they have not a lot. And there are very little mechanisms to collect money, even if you have child support or spousal support. There are a lot of people who don't pay or they stop working, and you can't collect money from somebody who's not making money. So women are more likely to live in poverty than men. Women of color are more likely than either white men or white women to live below the poverty line because of things like systemic racism in place. And women, again, we continue to shoulder the major responsibility of raising children. So all those things combined lead to women having more high-risk behaviors. So maybe alcohol, mommy wine culture that is all over social media right now. So using alcohol to cope, potentially cigarettes, other drugs to cope. Out here in Colorado, everybody is like, are you Mary Jane friendly or whatever we're calling it these days? It's probably the same in Maryland too, because didn't Maryland just legalize recreational marijuana too? Right. We have worse access to care. Do you know how hard it is to go to an appointment if you don't have childcare? Or if you take your child to the appointment, do you know how much you get out of that appointment? Chasing your toddler around, dealing with your crying baby while you're trying to have an appointment for yourself. Many families that I know in the military only have one car. And so when the spouse is at work, the wife has no way to get to the appointments, especially in areas like Colorado Springs where public transportation is trashed, right? And so all of these things combined lead to poor health outcomes for women. All right, so, looking at some, our health status today, and, what pharmacist role in women's health. So, again, the Affordable Health Care Act, or Affordable Care Act expanded women's health coverage for preventative care, and Medicaid also covers family planning and including contraception. So contraception is one of the ways that women can have control over their health. And so access to birth control or contraception is huge for a woman to be able to take care of themselves. And so there are many states where pharmacists can prescribe birth control. There is in Maryland. And you do need additional training. There are 29 states and DC that allow pharmacists to prescribe. So that's a step in the right direction, because pharmacists are definitely an underutilized and essential resource for so many patients, especially after Dobbs, when all these OBGYNs are leaving the states where abortion is not legal and going to other states. We are leaving OBGYN ghost land or wastelands for patients. And so the only provider they have available to them to get their medicine, birth control, is the pharmacist. So the pharmacist's role in prescribing and dispensing contraception is huge, especially in those states where abortion is illegal and OBGYNs are leaving. We also, we talked about the socioeconomical. We need to talk about the psychosocial and how we raise our children. Women and men are raised differently, treated differently, socialized differently, and taught to think about based on their sex. The thing that really grinds my gears as a parent is like, is it a boy, girl, like toys? You see like the Christmas list for best toys for boys, best toys for girls. And it's like, what the heck? Like, how is it different what the kids want to play with? Sure, if you need your genitalia to play with a toy, it's not a child's toy. It's a toy. So, my son had a doll that a friend gave him, and they're like, oh, some people would comment like, oh, why does your son have a baby doll? Like, because he's learning to be a good dad. Like, his dad is very active in his life, and there is nothing wrong with him having a soft doll to cuddle with. Like, take your stuff elsewhere. He wanted some garden gloves and they were purple. And my mom was like, why would you want purple gloves? Why don't you want a boy color? Like, he wanted the purple gloves. They were Paw Patrol. Let it go. Move on. Like, so we do this, whether, that some of it is our unconscious bias, and some of it is, ingrained in us. So really paying attention to that. Again, looking at the lens that we used to think of women's health as just the reproductive health, but now we should be looking at women's health from a physical and mental and social well-being standpoint, and not just whether they don't have disease and whether they're in their reproductive era. Right. So thinking about the differences at different stages of life here, in childhood and adolescence, girls are at greater risk of substance abuse, motor vehicle accidents, sports injury, emotional bullying, and physical fights. By age 13, twice as many girls are depressed as boys. I would imagine that this data, it's probably a little bit outdated with more and more kids on social media, and social media algorithms being programmed to make kids feel worse. in child and adolescence, we get sex education, and we start menarche, which is menses, having periods. And then the beauty norms that we see in society typically praise thin figures, and so that can lead to body dysmorphia and eating disorders for children and adolescents. In young womanhood, we still are trying to conform to societal beauty norms, which can, exacerbate and continue those disordered eating habits. And about 1/3 of young women, so that would be, high school graduation, college, undergraduate students age, would 1/3 of those women report physical and sexual abuse from partners. In our midlife, in our 40s to 65, some of us are seeing a role change because we had kids in our 20s and they are leaving the nest and going to college. And now we're like, what do we do with ourselves? In my circle of friends, a lot of us had kids recently within the last couple of years or still having kids into the 40s. So some of us are just starting our families in our late 30s and 40s. So we have a huge dichotomy going on there. But the thing that's staying same is that our parents are aging and we have to help care for our parents. So regardless of whether we're dealing with our kids going away to college, leaving the nest, going out on their own, or we still have young kids at home because we had kids later, our parents are aging and we're having to deal with all of that at the same time. In our 40s is when chronic disease starts coming and obesity starts setting in. And then you have the reproductive aging, which has perimenopause and menopause, which everything that I've heard about, I am not looking forward to. And then we have these late life transitions where we're thinking about retirement. Because women live longer than men, women are often widowed at a higher rate than men. And think about that, how that affects them. They might not have worked as long. They might not have saved for retirement as long. And so that puts them in kind of a financial crisis when they become a widow, potentially. Women are at increased risk for Alzheimer's disease. And then we have safety issues related to falling. So let's shift gears a little bit to talk about women's health research. We talked about research in CRD. We're going to talk a little bit more about women's health research specifically and how that came onto the scene. And so in 1947, you all should remember that we talked about the Nuremberg Code of Ethics. And this basically said that it was unethical to do research on pregnant women and children because they're vulnerable. So they were almost mostly excluded from trials. So that's where our problem starts. Then in 1974, we have the federal guidelines for the conduct on human subjects and research. And these are federal guidelines that further restricted involving vulnerable populations, including women of childbearing ages. So this led to a decrease of women participating in clinical trials because of concerns to risk of the unborn children. And these restrictions were reinforced because we had a drug on the market that was used for, and I can't remember if we talked about this in CRD or not, but used for nausea and vomiting of morning sickness in pregnancy. And it was thalidomide. And what we found, it's hard to see on this screen here, but if you look at the picture in your slides and blow it up, these children have flaps for arms because it is a birth defect from their mother taking thalidomide to control the nausea and vomiting while they were pregnant. So again, these policies were designed to protect women, but they inadvertently excluded, all women from critical research that created huge gaps in our knowledge of how medications work and treatments work in women, and knowing that there can be differences in how these treatments affect women compared to men. So we didn't have any changes in policies until the 1990s, right? So again, here's that, 1977, we have women in trials, drug trials. here we're still excluding women of childbearing age in phase 1 and phase 2 trials. It was very cautious. Again, this was due to the thalidomide. In 1985, we had the Public Health Service Task Force. And this report said, like, we need long-term research on how behavior, biology, and social factors uniquely affect women's health. We are missing key data to help a huge subset of our population, and highlighted the gaps in the research. In 1986, the NIH Advisory Committee on Women's Health started giving grants and contract publications, or started having grants and contract publications that stress the importance of including women in the research. So it was 1986 before we see a shift and say, we need more women in these clinical research. And this is when it was determined that if studies were going to exclude women, they had to have a very specific reason why they were going to exclude women from their trials. In 1990, we had the Women's Health Equity Act. Congress started to investigate why NIH was failing to fully implement guidelines promoting women's inclusion in research. And so this is when, because the NIH was not including women at the rate that Congress thought, there was an Office of Research on Women's Health created, ORWH, to help ensure that we were getting women into these trials and that their health needs were being adequately addressed. So this is really when we start to see things shift, is the 1990 era. In 1993, we have the NIH Revitalization Act that Congress passed that mandated that women and minorities be subjects in clinical trial. In 2012, we have Women of Color Research Network and the National Institute on Aging start to create a network that's going to support professionals, providing resources on how to get an NIH grant process and sharing information, promoting the research in women of color. In 2016, we see a policy, an NIH policy on sex as a biological variable. And so this tried to ensure that researchers considered how sex influenced health and disease early in the disease process and consistently in the disease process. In 2019 and 2020, we see research focused on sex and gender and maternal health through the NIH and that ORWH, looking for proposals, looking at the intersection of sex and gender and health and disease, really starting to take a look at maternal morbidity and mortality, because even though, you think as time goes on that we should, our maternal morbidity and mortality should stay steady, we're actually starting to see an increase in maternal morbidity and mortality, especially in women of color. And that is really scary, considering that it had been stable for so long. And now all of a sudden, women are dying during and after birth at an exponential rate, especially women of color. So we're like, hey, we need to look into this more. Right, so next we have the FDA Office of Women's Health, or OWH, and then we have the Department of Health and Human Services of Women's Health. So these are two of the key federal organizations that advance women's health research and promoting equitable healthcare policies. You can read more about them on the screen. And during the Biden administration in 2023, he created a task force and issued an executive order to help improve women's health research and advancing women's health research, with trying to, again, continue to fill those gaps in women's health research. So here we are, 1985 is when we're like, hey, we need to start looking at these, filling these gaps for women healthcare and women research. And here we are almost 20 years later, and we are still trying to make organizations and groups and executive orders that promote the research of women's health. So that's almost 40 years, right? Like, that it's taking us, and we're still having all these gaps despite all these policies, all these offices, all these things created to help improve that. But we do have some key research available related to women's health. We have the Nurses' Health Study that started in the 1970s because, and even still today, you'll see influencers that like to spread misinformation about how damaging taking birth control is to a woman. So the same thing was thought in the 1970s after birth control became more widely available. Is like, how good can this be for women? It can't be so good for them. So in the 70s, we started looking at this. There was 120,000 women. They did yearly questionnaires on whether they were taking contraception and how it was affecting them. We have the Nurses' Study, Health Study 2 and 3, and this started when the people from the first studies stopped answering their questionnaires. And so we still wanted to get more information. So we started a new study with a new cohort launched in 2010. And it also included other healthcare professionals. And it includes both men and women in their trial. And then the Women's Health Initiative is the one that is often quoted and often given credit to things for things like making sure that women of postmenopausal age have calcium and vitamin D to prevent osteoporosis and get screened for osteoporosis, and that they have breast and colorectal cancer screening. So the Women's Health Initiative was a 12-year study looking at hormone replacement therapy and how that affected the aging woman as it relates to their diet, their calcium, and osteoporosis risks and things like that. But the Women's Health Initiative was huge in implementing our guidelines as it relates to managing postmenopausal health. So looking at the differences in gender and morbidity and mortality, just going to breeze through some of these things here. So looking at mortality, so how long a person is expected to live, you see that the female has a longer lifespan compared to the male. Women are living to the average age of 80. This is 2021 data, which is the most recent data I find. And men are living to about 75 years. So women are typically outliving men by 5 years. Notice we do see this huge dip in life expectancy. Why do we see this huge dip in life expectancy at 2020? COVID, yes. COVID significantly impacted life expectancy for everyone. Next, we see like causes of death for women versus men. So we have males here on the left and we have females on the right. We see that other and health disease or heart disease are pretty consistent. Cancer is pretty consistent. We see more men die of unintentional injuries, which, you know, if you're like Ernesto and you're skydiving, that makes sense, right? But more women are dying of Alzheimer's disease and stroke compared to men. Here we see cardiovascular disease. We see that men do have higher cardiovascular risk than females. This is heart disease death. So women or men do die at a higher rate from heart disease than females. And the lines are pretty steady. Here we see just cardiovascular death rates. And we do see that they're dropping, but we do still see that men's cardiovascular death is higher than females. Next, we have cancer, and we do once again see that men have a little bit higher cancer rate, and these is cancer death due to cancer. So they do have a higher rate of death due to cancer than women there. Right. So we've talked about a lot of things today, a lot of hodgepodge of things affecting women's health. We looked at policies that impact women's health, looking at the socioeconomic status being the largest social determinant of health, looking at the gaps in research and how we've tried to close those gaps and how we're still after almost 40 years trying to close those gaps in women's research. And then looking at kind of the differences on how women age and die compared to men. That's a lot. What questions do you have? What things struck you that you want? Any comments? Concerns? Have you all had public health? No? Okay. Okay. Yes, Kingsley.
I'm looking at the definition of women's health, and I'm trying to compare that with the World Health Organization in 1948, which seems to be similar, as health don't being the absence of disease, but something that is holistic, that talks to body, socioeconomic, political, and emotional well-being. When this definition was given in 1948, was it not all inclusive for male and female? Why did we have to still create another niche for the female later in the 70s when we were trying to create the women's health? Because I was looking at the definition as it has metamorphosed over time. It seems as if it went back to 1948 to reinforce the same definition that the World Health Organization had given with respect to the definition of health.
Yeah, so I'm not sure. If that 1948 definition was meant to apply to women or men, but regardless of whether it was meant to apply to women and men, society has treated women's health differently than men's health. And so I think that this Fourth World Conference that came out in the 90s was trying to reemphasize that women's health is more than just reproductive care. So it might have been just a reminder, but I can't speak to that definition that you're talking about from the 1940s. But I would suspect that because we were having such an issue with defining women's health, that this World Health Conference was like, hey, we need to redefine this. We need to put this back out there. We need to put this in people's faces, would be my assumption of what happened. Because as you saw with the research, all that stuff started in 85, and we're still having to create more policies and task force to help increase the women's health research. So.
Thank you.
Yeah. All right. Well, if there's no questions, as always, I'll stay on for the next 9 minutes to make sure you get your money's worth, but please check in the next 9 minutes, make sure you're on the list, and then send me an email if there's somebody you absolutely can't work with. The group one, your email will be sent at 4 o'clock today. It's scheduled to send to you at 4 o'clock for you to start working on that. Yeah, if you have any questions, let me know. It's really great to see you all. Thank you for your participation. And for those of you who are able to have your cameras on, I always appreciate being able to see you and everything. So I will see you on Friday in PT, and then next week in back here for Women's Health.
Thank you, Dr. O. Dr. O, I have a question.